Okay. Any questions about anything with the test coming up on Friday or anything before we get started? Okay. I think we're good. All right. Okay. Well, we wrapped up last time, kind of finishing up talking about the menstrual cycle, female reproductive system, all of that. So we'll spend a little time here with the male reproductive system now. So just kind of a little basic overview of some of the functional anatomy here that's important to understand. So we've got these different all parts of this tubular system here in the testes. And so the seminiferous tubule is kind of the deepest part. Okay, this is where sperm development starts. Okay, so that's kind of the deepest part of this tubular system. This is where the mitotically dividing cells are. We'll look at those in a sec, what those are, but they're called the spermatogonia, which are going to be producing the sperm. So that's all kind of in the deepest part. And then from there out into the epididymis here. And so this is another just series of ducts, kind of the posterior part of the testes. The function here would be sperm maturation. Okay. This is where all the swim lessons are happening here. Just kidding. Yeah, I know. Good joke, right? Yeah. Got to have a couple jokes with the reproductive system. But yeah, so swim lessons here. Then the vas deferens, right? So the vas deferens we can see here. And this is where a vasectomy happens, right? So vasectomy, right, is removal of part of the vas deferens, right? So that vas deferens is it's a canal that's going to connect the testes to the urethra, right? And it's lined by smooth muscle, and ejaculation makes that smooth muscle contract. And so with vasectomy, a little portion of it is cut out, right? So it's kind of like a little chunk of it is cut out. Both ends are typically cauterized, so there's just no more connection between the testes and the urethra in that way. And so, yeah, this is pretty much 100% effective birth control if all the steps are taken properly, but only 50% reversible. So it is a form of sterilization. So it's kind of, there's lots of legal issues around it and stuff because there's been many countries in the past that have kind of forced sterilization on people. And so, yeah, vasectomy, same thing as tubal ligation. Kind of there's lots of paperwork and making sure you know what you're getting into and those types of things. Yeah.
Into it, but it's the new form of male birth control. It does something about like the development of the sperm. Do you know anything about that?
I have not. No, I haven't seen that. Yeah. Send me an article on it. I'd like to see it. But yeah. Yeah. So that's pretty much what I wanted to cover there. Any questions on this part, kind of the functional anatomy to start? Okay. All right. So then the process of the formation of spermatogenesis, involves these two cells, and so these are kind of the adjuncts to the cells that we talked about in the female reproductive system. So we've got the Sertoli cells, and these Sertoli cells release one important protein called androgen binding protein, and then they also release inhibin. Okay. These cells contain that aromatase enzyme that we talked about in the female system as well. And so then they can produce estrogen. Okay. All sperm development is androgen dependent. Okay. And so androgens, again, can come from the testes, but they can also come from the adrenal cortex, like we talked about before. Okay. And so we see on this image up here, the Sertoli cell is kind of all of this pink background kind of behind these developing sperm cells. Okay, so they're kind of these larger cells that are that the spermatids are just embedded in. Right, so they're very involved in the development of sperm from the early stages until they kind of leave the deeper part of the testes here. And then the Leydig cells are the primary source of testosterone in males. And the late egg cells are similar to the interstitial cells that we saw in females in the ovaries. Okay, and so those late egg cells are kind of outside of that area where the sperm cells are, and so they can convert androgens that come from the adrenal gland to testosterone. And so, yeah, so we can kind of see this process here of kind of very early spermatids here, secondary, primary spermatogonium, right? So these are the stem cells kind of in the deepest layer that are mitotically dividing and then producing the primary spermatocyte, secondary, and then finally early spermatids. And then they kind of develop even further here to these late spermatids. So they're still embedded in those Sertoli cells until later in development, then they go on to the next part. So yeah. The other thing that I'll mention just about these androgen binding proteins is they kind of work to clump together androgens that are just in the circulation, which ends up kind of increasing the levels of androgen hormone that is found in the testes. And that's an important piece for sperm development. It's kind of a way just to kind of collect the androgens from the bloodstream and bring them to that area. And that's an important piece of those developing sperm. Okay. Questions on that at all? Okay, so then semen is typically just 2 to 5 mils of fluid. Only about 10% of that is sperm, which is about 100 million sperm per mil of semen. Okay, and other components of semen include buffers to neutralize the acid in the urethra and the vagina. And that acidity is there typically because of the resident bacteria that are producing some lactic acid. There's fructose found in semen, which fuels the activity of the sperm. And then prostaglandins as well. And we've talked a little bit about prostaglandins. These can stimulate uterine contraction, can also stimulate the thinning of the cervix a bit. And it's actually one of the common things that an OBGYN will recommend to try to stimulate labor would be have intercourse because the prostaglandins found in semen, it can start that process of thinning the cervix. Then there's also clotting factors found in semen, clotting factors which help the sperm to kind of stick to the walls of the vagina to kind of give them a better chance of making it all the way. And then we talked about this with ejaculation, that this is a function of the sympathetic nervous system, right? Whereas erection is a function of the parasympathetic nervous system. And yeah, there's kind of this little kind of function that happens when sperm get past a certain point in the vagina and up into the uterus and cervix where it becomes less acidic. That activates these alkaline sensitive calcium channels called cat spur. And I like to think of it like a little kind of power up, Super Mario Brother power up, and it kind of activates them and they start swimming faster, right? It's kind of this super interesting thing. Another amazing things is sperm have olfactory receptors on them, which kind of drives them towards pheromones that are released by the ovaries. So they kind of get some direction in which way they're going. But there's hundreds of millions of them, right? So typically only about a dozen make it up to where the egg might be in that area, and obviously they have to take a turn, right? Go right or left down either fallopian tube, and there's only going to be an egg, if there's an egg at all, in one side, and so typically only somewhere around 10 to 12 actually make it to that point where that could happen. But starting with hundreds of million to begin with. So yeah, interesting journey. Come on in. Okay, questions about that at all? Okay. All right. Yeah, and then just a couple things about erectile dysfunction. Erectile dysfunction is extremely common in men over the age of 40. So 50% is the statistic. So half of men over the age of 40 have some form of erectile dysfunction. The most primary cause is damage to the artery walls, which is not necessarily just in the penis, but throughout the whole vascular system, right? And this is part of cardiovascular disease. Part of cardiovascular disease is damage to endothelial cells in blood vessels, and that includes the blood vessels here. And we've talked about nitric oxide a little bit. Nitric oxide is the chemical released from those endothelial cells, which leads to vasodilation, which leads to engorgement and erection. And in the very first stages of cardiovascular disease, nitric oxide production declines in those endothelial cells, and that is connected directly to erectile dysfunction as well. And so that is the primary cause. Another cause that's been coming on the scene and being recognized more in younger men is what's called pornography-induced erectile dysfunction, which is more of a neurological problem, not so much a peripheral physiological problem related to just having kind of unreal and not normal stimuli that leads to erection, which then kind of trains the brain to only be stimulated with that level or that type of not normal sexual interaction. And it leads to younger men, not being able to get an erection. So yeah, so kind of just two, obviously the main causes here, but starting to see a lot more of that in younger men as well, which is concerning for sure. So a couple of the treatments that we all know the names of, because for the longest time there were many, many commercials. Now everything has shifted a bit to more kind of over-the-counter versions or other ways to get this. But Cialis and Viagra, right? All of these are phosphodiesterase inhibitors. Okay, so when we talked about how smooth muscle contraction works early in the class, right? And the main way that muscle contraction works, smooth muscle contraction works, right, is activation of that MLCK, right, which leads to the phosphorylation of myosin and then the activation of myosin ATPase. But then the way that the smooth muscle relaxation works is by activating MLCP, right, myosin light chain phosphatase. Okay, and so both these mechanisms, so phosphodiesterase is related to activating and activating or blocking, actually, yeah, phosphodiesterase blocks cyclic GMP. Okay, and cyclic GMP is related to smooth muscle relaxation here, right? So if we can cause smooth muscle relaxation, that's what leads to vasodilation, which leads to erection. And so these drugs were discovered as treatments for initially as treatments for cardiovascular disease because they're along the same lines, and then turned out that they worked for this as well. So that's one kind of class of drugs. And then there's these cyclic AMP activators. Those would be the ones over here. Okay. And so again, if we can activate cyclic AMP, this is going to lead to smooth muscle relaxation. So that's just another way to do that. Right? So we can either kind of inhibit phosphodiesterase or we can activate cyclic GMP. Those are the two primary ways that those drugs work. So. Okay, questions on those? Okay, all right. So we'll talk about kind of the primary hormones in the male reproductive system here and some similar ones, right? So we've already been talking about LH and FSH. Again, the names here are nothing to do with what they do in males, right? It's all based on the female functions. But LH, the primary action here is going to be stimulating those Leydig cells to release testosterone. Okay, FSH is going to be stimulating the Sertoli cells. Okay, so just like in the female, we kind of had the matching of LH going to a certain cell, FSH going to a certain cell, right? So LH is going to be Leydig cells, the L's go together, FSH going to be stimulating those Sertoli cells. Okay, and so that's just that FSH activation of the Sertoli cells is just all about kind of sperm development and production. Okay, and then inhibin is also released here, just like it was in the female reproductive system, and that's related to the Sertoli cells and their activation by FSH as well. So testosterone is also important for sperm development, and then obviously all of the male sex characteristics as well. Yeah, and then inhibin is going to have some negative feedback effects, just like we talked about in the female. Okay, let's talk a little bit about testosterone and what it does and how it's formed. And so, just like any cholesterol-based hormone, it gets in through the cell membrane and acts on an intracellular receptor, right? So, and then just like all of the cholesterol-based hormones we talked about, all the steroids, they activate transcription in some way, right? So they're transcription factors in some way, and so we can see all those effects here. Again, another key enzyme here is this 5-alpha reductase, and yeah, and so that's just another one to think about there. The exogenous testosterone is like people that inject testosterone into their bodies, right? So not endogenous that your body makes, but exogenous is a drug that can be commonly abused in athletics and sporting events. And one of the problems with exogenous testosterone is that we'll see on the hormone loop here in a second, but testosterone is what provides the negative feedback for the release of FSH and LH, right? And so if there's an excessive amount of testosterone in the body, then we stop releasing FSH and LH, right? And that means we're not getting the same effects, or not getting the normal effects of FSH and LH. Still have the testosterone and plenty of it, but not getting the other powerful effects of FSH and LH. And a lot of that has to do with sperm development, right? And so that's very common for people using exogenous testosterone to to have fertility issues. Right? Yeah, because the hypothalamus is sensing that high testosterone, we'll have a decrease in GnRH, right? Which then leads to a decrease in LH and FSH. And then these are going to lead to infertility. Okay. Questions on that? And so this would be kind of a similar image to what we saw in the female reproductive system, where we see LH leading to the production of testosterone here, but in females, it was the production of estrogen. So yeah, awesome.
What's the significance of the 5-alpha reductase?
Yeah, so it's just kind of this key step in leading to the kind of the action of testosterone. So yeah, there's kind of the different receptors we find inside the cell, right? So this is testosterone getting into the cell, and then it can, yeah, from there it can be kind of converted into one of the androgens that we talked about. I mean, the DHT is one of the androgens we talked about. And so those androgens are key for spermatogenesis and other things like that. So that enzyme in some cases can be not working properly, or it can also be targeted by certain drugs. So yeah. Okay. All right. And this will give us a little bit more detail about the side effects of anabolic steroid use or exogenous testosterone use. Kind of already went through the infertility piece. And in this case, when there's too much testosterone, we don't get LH and FSH release. That leads to the Sertoli cells not getting stimulated, and they can even die. One of the other functions of the Sertoli cells is to create the blood testes barrier, right? Because the DNA of sperm, it doesn't match exactly the DNA of the body, and so if sperm is able to kind of get into the bloodstream, then the immune system reacts against that, right? And so there's this important barrier there, but Sertoli cells help us to create that. And so without stimulation of those Sertoli cells, they can be the blood barrier can be lost, which can then destroy the ability of the testes to produce sperm permanently. Yeah, and then cardiovascular disease is related to this. Testosterone levels, high testosterone activates the liver to produce more cholesterol, and kind of too much protein synthesis in certain areas like the heart can lead to heart failure. And so that's connected to that. the liver can be damaged because the liver's responsibility to metabolize all of these extra steroids. Definitely central nervous system, instability, rage, these types of things. Gynecomastia. So gynecomastia is breast development in males, which would be kind of seen here. And so when there's just too much testosterone on board, way more than is needed, the body has the ability to convert that into estrogen, and that happens in males that are taking way too much testosterone, that can then start leading to some female sex characteristics coming about. Sebaceous oil glands in the skin are activated by testosterone. That's why puberty leads to acne, right? But this is just way extra activation of these sebaceous oil glands can lead to this ulcerated acne on the chest, on the face, on the back, those types of things. So these are just some of the kind of negative consequences of exogenous testosterone use. So, okay. Questions on that? Okay, well, let's look kind of at this hormone loop here. Actually, why don't you guys take a sec and fill this in? So we've kind of got our hormones coming from the top there, from the hypothalamus, right? And then that's going to lead to the release of two hormones from the pituitary, which each of them are going to go to specific cells there. So see how much of this you can kind of fill in and just kind of discuss the overall effects there of testosterone. We'll come back together in just a sec.
Maybe, oh, you know. Yes.
Okay, so the generation question.
Yeah.
I know that a lot of people in my family have used testosterone as like kind of like a steroid for them. I had a friend that did that, but their muscles ended up getting really weak and they ripped off their entire pectoralis major. And it's like a surgery that people like if all the students were watching because it's not
So yeah, I mean that is one of the consequences of because like when you do resistance training to build your muscle, like that gives time for your tendons to get stronger and for your bones to get stronger and everything. When it's just through testosterone, the muscle can kind of build faster than the other tissues, right? And so then it's like you get kind of freak injuries like that where yeah, muscles are ripping off of bones. You get like avulsion fractures too. That's another thing. There was a NFL player who ripped his quad tendon off of his tibia, and he was definitely someone who was using steroids. And so there's some stuff like that where it's just kind of like the growth in muscle is quicker than those other tissues. And yeah. So,
what was causing it. Everybody's like,
yeah.
makes it grow fast, but it also can be detrimental.
Yeah, because everything needs to strengthen to support that extra strength, and it's just a little bit slower. But yeah, no, that's a good question. Yeah.
Yeah, because Sertoli still is producing music.
right, let's go ahead and come back together here. Okay, so what is our hypothalamic hormone here? GnRH, okay, so we got a GnRH release. That's going to go to the anterior pituitary and cause both LH and FSH to be released, right? So two there would be FSH. FSH goes specifically to the Sertoli cells and causes what? What would you kind of broadly say? Sperm development, yeah, sperm development and production, right? So we're seeing that aid in sperm development, okay? And this is that Sertoli cell, right? It's that big kind of cell that the sperm are embedded in, right? And then 4 there is our LH, right? LH is going to be stimulating those Leydig cells to release what? Testosterone, right? So that's number 5, testosterone there. And then we see a couple different things going on. We see some negative feedback caused by testosterone there to both the pituitary and the hypothalamus, right? So it's going to kind of regulate the amount of GnRH release and LH and FSH release, right? So that's the negative feedback there. And then we see inhibin release as well that's also causing negative feedback. And then we just see the actions of testosterone, kind of the 3 broad effects of testosterone would be number 1, those secondary male sex characteristics. Okay. Number 2 would be the sperm development, right? And then number 3 would be growth, right? It's an anabolic hormone, so we get growth, we get sperm development, and we get also secondary sex characteristics. So let me try to make it a little bit more clear on the testosterone and androgens. So testosterone themselves or itself can go in and lead to some of the sperm development. But then what this was trying to get at was that testosterone can also be converted into an androgen, DHT, and that androgen actually has a little bit more powerful of effect in sperm development and kind of binds more effectively to some of the receptors that are activating sperm cell development. So both testosterone and androgens are involved in sperm cell development, but the androgens tend to be the more key player there. Okay. Questions on that? Yeah, go ahead. Yeah, sure. I can just write it here too. So the 3, so 1 would be secondary sex characteristics. 2 would be sperm development. And 3 would be growth. It's an anabolic hormone, so it leads to activation of protein synthesis all over the body. Okay. Yeah, go ahead. For specifically for sperm development, yes, but not for growth. Testosterone is a more powerful anabolic hormone, but for sperm development specifically, the androgens are kind of the more key player there. Yeah, thank you for asking that question. Okay, other questions? Yeah. Yeah, so androgens are coming from the adrenal cortex through the bloodstream, and some of those are making their way to these Sertoli cells, and so those are activating and dealing with sperm cell development. And then we also have testosterones coming from the Leydig cells, making its way back to these Sertoli cells, and then some of that testosterone gets converted via this 5-alpha reductase back into androgens in those cells, and then it can be used for stimulating the process of sperm development there. So, good question. Yeah, go ahead, Daniel.
So this picture, the DHT is that blue molecule?
The DHT is, what did you say? Oh, the blue. Yeah, I think it is. Yep, it is. Yeah. So it's, yeah, it's showing like this would be the yellow one is a testosterone. DHT is after it gets converted. It's showing that testosterone can bind here and activate all the things that need to be activated. But the DHT does it as well and does it in a little bit more of a powerful and effective way. Okay. Other questions on that? Okay. All right. Well, we're gonna switch gears and talk about the pancreas next. Okay. And so we'll talk about the pancreas more in its exocrine functions when we get to the digestive tract coming up in the next couple weeks. But we're going to focus on the endocrine functions here. But we'll just kind of a quick overview. The exocrine functions are driven by cells called Acini cells. Okay, and the Acini cells are what make and release pancreatic juice for digestion. Okay, so all kinds of pancreatic enzymes are made by these Acini cells and released. Okay, so those are all exocrine functions because those things are released into the digestive tract, which is considered outside the body. Okay, and then the endocrine functions are driven by cells found in the islets of Langerhans. The islets of Langerhans contain these four primary cell types. Okay, so these cell types include A cells, which produce glucagon. There's about 20% of those cells. Okay, the stimulus for glucagon release is low blood sugar. And the action is going to be to increase glucose levels in the blood. And that's mostly going to be by glycogenolysis, right? Breaking down stored glycogen and turning that back into glucose and releasing that into the blood. Okay, and then we have the pancreatic B cells or beta cells. This is 75% of these cells in this area. These are the insulin producing cells, right? And these insulin producing cells, the stimulus is going to be high glucose, right? And the action is going to be to decrease glucose, pretty much allowing glucose into our cells. We'll look at some more actions of it here in a second, but that's the basic kind of primary action is lowering blood glucose, getting it into our cells. Okay, we've also got D cells, which produce somatostatin. We will also see somatostatin production from some cells throughout our GI tract, not just here. Okay, so the stimuli for the release of this has to do with glucose and amino acids kind of in the GI tract. And then we'll talk more about CCK later, cholecystokinin, but that's going to also stimulate the release of these of somatostatin. Okay, so this one is interesting because it has more paracrine actions than it has endocrine. So paracrine means it just goes kind of to tissues that are just adjacent to it. So it doesn't necessarily go through the whole bloodstream and affect the whole body. It just affects things that are real close to it. Okay, so the paracrine actions include inhibit some of the other release of the two other hormones we just talked about. Okay, and slowing down gastric emptying. So this is kind of regulating digestion by slowing down the digestive processes a bit as food enters a certain area. It's like we'll kind of go back one step with somatostatin, kind of slow that down so we're not adding more to that area while that part is being digested. It's kind of the idea with somatostatin here in its paracrine function. And then lastly, the F cells produce something called pancreatic polypeptide, which is stimulated by protein consumption, by exercising, by some of these other functions. And this is also kind of slowing down and regulating absorption of food. Okay, we won't spend much time on those bottom two here. We'll talk about some of that stuff more when we get to the digestive tract. We'll spend some more time talking about insulin and glucagon. Okay, So let's dive into insulin and its actions here. So it's a protein hormone, right, which is what makes it more challenging to kind of work with and test. We don't have good point of care tests of insulin, right? We do have glucose, but not of insulin. It's an anabolic hormone. We don't really think of insulin as an anabolic hormone, but it is. It leads to growth. Okay, it's really kind of known as a hormone of abundance, right? So we have lots of nutrients on board. Insulin is there to kind of help us deal with and put those nutrients into our cells. Okay, so storage of carbohydrates, proteins, and fat, right? So we have excessive nutrients or just a good amount of nutrients. Insulin helps us distribute those nutrients and get them where they need to go. Okay, so we have lots of different glucose transporters in our cells, and these are typically all called GLUT something, right? So GLUT 1 through 7. GLUT 4 is the one that's stimulated by insulin. Okay, so GLUT 4 is kind of the key glucose transporter that's sent to the surface of cells when insulin binds to that cell. Okay, GLUT 4 is also stimulated directly by the action or just by exercise. And so this is a nice image that kind of shows that. We can see the insulin receptor here. That insulin receptor, through a series of events, leads to GLUT4 coming to the surface of the cell, but then also exercise directly independent of insulin by the change in ATP status of the cell. Meaning that when we start using up our ATP, we turn on this molecular regulator, AMP kinase. That leads to GLUT4 coming to the surface of the cell. And you guys know that when we contract muscle cells, we release a bunch of calcium into the cells, right? And that activates calmodulin proteins in our skeletal muscle cells that also activate GLUT4 coming to the surface of the cell. Okay, so the idea would be that we have GLUT4 kind of found in a bunch of vesicles in our muscle cells in particular, but in fat cells and other cells as well. And it's kind of just ready to be sent to the surface, but insulin kicks off the process that causes that vesicle to then go to the surface of the cell and implant all those GLUT4 proteins so we can get that glucose into the cell. Okay. It also acts in our intestines and kidneys. Okay, so another type of receptor here, which is important for absorption of glucose in the small intestine and the kidneys. This is a one that uses co-transport with sodium. And so insulin leads to increase in those SGLT1 and 2 transporters going to the surface of our intestinal cells and our kidney cells. So we get more, so we pull back more glucose from our urine instead of releasing it, and we absorb more glucose in the face of insulin from the GI tract. Okay, also acts to increase potassium entry into our cells. So this is kind of just a table that walks us through some of these things, right? So kind of our rapid effects of insulin are the ones we've been talking about, right? So increase glucose, amino acid, and potassium. And then we kind of have these somewhat longer term intermediate effects. So protein synthesis, we're breaking down of protein, activating glycolytic enzymes. And then lastly, some delayed responses would be increasing messenger RNAs for lipogenic and other enzymes. So yeah, so building up fat as well. That's what lipogenesis is, right? Is adding fat cells and adding fat to fat cells. So yeah, so lots of different effects, but probably the easiest way to think about it is all things dealing with holding, when we have lots of nutrients on board, dealing with those nutrients in some way to produce part of our body, cause some growth, use those in metabolism, some all kind of related to those actions. So questions about that? Okay, so let's talk a little bit about diabetes mellitus. So diabetes mellitus is specifically diabetes that is related to having high blood sugar, right? We'll talk a little bit more about it later, but diabetes insipidus is the reason why mellitus needs to be called mellitus here. Diabetes insipidus is when we don't respond to ADH, right? And vasopressin. And so back in the day, this is when doctors would sip patients' urine, right? If you guys have heard that story. And so the urine was tasteless with insipidus, but with mellitus, it tasted like honey. It was sweet, right? And so that was how it got this name. But the common thread, well, does anybody know what is the common thread across all types of diabetes? Yeah, there is just lots of urine, right? And then that leads to lots of thirst as well, right? So excessive amounts of urination was kind of this thread that tied together all the types of diabetes, right? And then there's one type that leads to sugar in the urine, one type that just leads to lots of water in the urine, right? So these are all the sugar part types, right? So diabetes mellitus, type 1 diabetes is autoimmune. Okay, so for some reason, there's some cellular trigger that gets into the body. The kind of general theories think it might or show it might have something to do with a virus that gets into the body and triggers the immune system to produce antibodies that also bind to beta cells, right? So those pancreatic beta cells and destroy them, and it destroys all the beta cells. Eventually, early on in the diagnosis of type 1 diabetes, there's still some beta cells left, and they're still producing some, but later on, they're pretty much all gone. This is only about 5% of diabetics in the US, and it's no longer known as juvenile diabetes because it can come about a little bit later into the 20s, but not too much later than that. Yeah, and then type 2 diabetes is the primary pathology is that mechanism we were just looking at with insulin binding to the cell, causing all those things to happen to make GLUT4 come to the surface of the cell. There's multiple problems in that chain of events, and that's what's called insulin resistance, right? And so the result of this is people need more and more insulin to be released to get the same amount of glucose taken out of their blood, right? And this is 95% of US diabetics, so much, much more prevalent. But type 1 diabetes is on the rise as are all autoimmune disorders for the most part. It's drastically increasing in the past 10 to 15 years. Yeah, and then gestational diabetes is the insulin resistance that's very similar to type 2 diabetes, but it just comes about during pregnancy, and then it goes away after the baby's born. And it's just kind of this strange phenomena that yeah is about somewhere between 2 and 10% of U.S. pregnancies. There are some health risks for the baby if it's not treated properly, right? So there are risks of definitely a greater risk of obesity and type 2 diabetes in the child later in life if mom's blood sugar isn't controlled properly during pregnancy. Yeah.
The moms technically after birth just develop like type 2 diabetes and have.
There is I think a slightly increased risk of type 2 diabetes development in mom, but it's not like a super tight link. Like most of the time it just goes away. Yeah, yeah. Uh, yeah. Other questions? Yeah. Yeah.
Goes away after delivery most of the time.
Yeah.
But it's still considered gestational diabetes or what would be like what Riley was saying, like type 2.
If it doesn't go away? Yeah, it's a good question. I don't know of any cases where like that kicked off type 2 diabetes in individual, but I haven't studied it in detail either, so I'm not sure. But yeah, Margot.
That it increases risk of type 2 diabetes for the baby.
For the kid, yeah, yeah. Yeah, yeah.
This case would pathology be hormonal or?
Yeah, it's somehow connected to kind of, trying to provide nutrients to the baby in some way. It's kind of like an overreaction to that because pretty much there's multiple things that happen in the mom to make sure nutrients are available and blood flow is available and all these different resources are available to the fetus, right? And part of that is a little bit of insulin resistance. So not all the blood sugar goes to mom, and so it's probably some kind of just a bit of an overreaction to that where it's just like leads to excessive amounts of insulin resistance and too high of blood sugar. Yeah, go ahead. Yeah, I think going into there are definitely risk factors. And I think definitely like genetic risk factors, like if your mom had gestational diabetes, that can be closer linked. Um, as far as prevention goes, I don't know if there's any way to prevent it. There's definitely ways to treat it, right? And it's all about just dietary control and exercise during pregnancy and monitoring of blood sugar. But yeah, I don't know if there's a lot of ways to prevent it. There may be. Again, I haven't looked into it in super detail, but I've more just studied about the treatment, which is just kind of trying to maintain glucose levels during pregnancy. But, yeah, good questions. Other questions? Okay. All right. So, yeah, let's talk a little bit about each of these a little bit more. So type 1 diabetes, again, the body can't get glucose into the cells, right? And so it turns to other sources for fuel, right? So it starts breaking down our places we have lots of protein available, which would be our skeletal muscle, okay? And then it also turns to fats, right? And so obviously our subcutaneous fat can be used, but the liver starts forming ketone bodies, right? And we talked about this some early on when we talked about metabolic acidosis, right? So ketone bodies are formed by the liver during starvation, and they're used very well as fuel by some of our key organs, brain, heart, and liver, right? But the problem is they're very acidic, right? And it drives our pH down, okay? And this leads to metabolic acidosis. Dehydration is one of the key things that can be life-threatening in type 1 diabetes, right? Um, this is all about having too much glucose in the blood, which then that glucose ends up in the filtrate, which will become the urine in the kidneys. And those SLGT transporters are responsible for pulling the glucose back out of the filtrate so it doesn't end up in the urine as the fluid is moving through the kidneys, but they just kind of have a max rate that they can work at, right? There's just a certain amount that of glucose we can pull back, and beyond that, it stays in. And so then the more glucose that's there, the more osmotic pressure is created in the filtrate, in the urine, which pulls more water with it too, right? So we're increasing osmotic pressure in the urine, which pulls a lot of fluid in. And so that's the main reason why so much fluid is lost in hyperglycemia. Oops. Yeah. And so excessive urine is called polyuria, excessive thirst is called polydipsia. So these are all symptoms of type 1 and can be type 2 diabetes as well. Diabetic coma is actually loss of consciousness due to, it can happen with high blood sugar, it can happen with low blood sugar. It can happen due to hyperventilation in a type 1 diabetic, right? So type 1 diabetic moving into metabolic acidosis can hyperventilate and pass out because of that. It can happen because of hypoglycemia. That's the dangerous ones, right? That's the very dangerous ones within an hour or two. With extreme hypoglycemia, the person can die from that. Can also happen due to severe dehydration, which will be more likely in hyperglycemia, not hypo, right? And then also what's called a hyperosmolar coma, where the osmolarity of the blood is so high, it messes with the function of neurons and can just kind of knock out their function for a bit because of water changes and ion changes that go along with that. So diabetic coma isn't just because of low blood sugar, right? That's one reason, but it can be also because of high blood sugar in these other cases. Okay. All right. So treatment of type 1 diabetes. Now, for the most part, most type 1 diabetics are on insulin pumps. And for the most part, most of those type 1 diabetics also have glucose monitors, right? And so it's really the common thing now, which is what's called the artificial pancreas, right? The artificial pancreas is two devices linked together, right? One device that's always monitoring the level of glucose in the blood, which is communicating with the insulin pump, telling that insulin pump how much insulin to release, when to release it. Yeah, this was something that was just a pipe dream 10 years ago. Really, it's a very new technology. It's been being developed for probably 2 decades before that, but it was finally just approved by the FDA not that long ago. Really, my son has type 1 diabetes, and he was diagnosed in 2018. And there was only one option on the market at that point, and now there's multiple. But it's yeah, and the reason for it is because insulin is a life-threatening medication, right? You give somebody too much insulin, and they die, right? So we're trusting computers and algorithms to to not do that, right? So it took a long time to get that approved, but it's life-changing for sure for people that are dealing with this. So yeah. One of the interesting parts about insulin production is Humalog is one of the primary insulins used on the market, and it's produced by bacteria. That's how it's made in the lab with all these bacteria that are just trained to pump out tons and tons of insulin, and they're kind of yeah. So it's kind of just an interesting side note. But questions about any of that? Okay. Let's yeah, I have kind of some review questions, but looks like everybody's getting a little tired and could use a quick bathroom break. So let's do a 5-minute bathroom break. And we'll come back and finish this up, and then we got some review. We'll probably still finish a little bit early. So 5 minutes, we'll come back. All right, guys, let's go ahead and start back up here again. Yeah, perfect. Okay, any other questions about type 1 diabetes before we talk about type 2? Okay. All right. There's all kinds of interesting new potential treatments for type 1 diabetes. If some of you guys have been following some of the news on that, all kinds of different things the researchers are trying, like different kind of nets to put around the pancreas that can actually block the immune system from destroying it, different stem cell work where certain cells are kind of injected into the pancreas that can kind of then replace the beta cells, and yeah, different immunotherapies to help with it as well. So my guess is maybe in 20 years we won't really have an issue with type 1 diabetes anymore. That's kind of the thinking right now. Which is amazing to think because type 1 diabetes 100 years ago was a death sentence, right? People just died when they had type 1 diabetes. That was it, right? Now it's it's a disease that you can live with and have a totally, almost totally normal life with, along with dealing with all the supplies and equipment and injections. But beyond that, people can live a totally normal life. And maybe 20 years from now, it won't even really be a disease that we have to worry too much about because it'll be so treatable. But we'll see. So. Yeah, well, type 2 diabetes, unfortunately, is a different story. It's not one that we can just kind of knock out with certain treatments. And there's a huge genetic component to it, probably somewhere on the higher end of this. Race and ethnicity are connected to this. Physical inactivity and obesity are directly connected to this as well. So there is genetic components, but it's definitely lots of lifestyle components as well that lead to type 2 diabetes. The progression of the disease is this mechanism of insulin binding to a receptor, and that leads to something like a 12-step process inside the cell. All these different little molecular regulators are getting activated, and then one of the outcomes of that is to make GLUT4 come to the surface of the cell. And so there's multiple steps along that pathway that are messed up with type 2 diabetes. And that's what insulin resistance is. So for a certain amount of insulin release and binding to a cell, we should get a certain amount of GLUT4 coming to the surface. But with insulin resistance, it's less. It takes more insulin to get that same amount of GLUT4 to come to the surface, to get that same amount of glucose taken out of our blood, right? And so the progression is that response becomes impaired. So then our pancreas starts just releasing more insulin when we eat, right? Which kind of hides the disease from us, right? Because we never see glucose levels rise until much later on in the progression, right? Because for many years before hyperglycemia happens, we have hyperinsulinemia, right? So excessive amounts of insulin release, which allows for those glucose levels to stay pretty much normal for years. And so that's kind of what's discussed there. And so the onset of actually elevated blood glucose might be years before, after this insulin resistance started. And this is kind of a problem in the way that we diagnose type 2 diabetes, right? We diagnose it by glucose levels only, right? Or by hemoglobin A1C levels, but that's not taking into account the fact that there's a problem long before that in the mechanism, and our pancreas is just kind of hiding that. And so if we can do something like an oral glucose tolerance test instead, where we give somebody a certain amount of glucose and we actually track their insulin levels in many people with prediabetes or even people before prediabetes, we would see a much higher spike in insulin, and then we would know they're kind of heading down this road, and we can kind of try to catch it earlier. To kind of make that hit home, when somebody's finally diagnosed with type 2 diabetes, when they have elevated glucose above 126 fasting, which is the diagnostic criteria, only 40% of their pancreatic beta cells are left at that point. And so their pancreas has been destroyed to that point where 60% of it is gone typically by the time we diagnose the disease. So that's why we look at prediabetes too, right? So prediabetes would be fasting glucose between 100 and 125. Right? I don't remember the hemoglobin A1C numbers off the top of my head, but the fasting glucose levels are there. And that is a really important number to look at too, because those people, it sounds like they don't quite have a disease yet, prediabetes, but they do, right? They're well into insulin resistance and well into pancreatic beta function declining as well, and their liver. We'll talk about how that's involved in a second as well. But yeah, so those are the big things, and then eventually, in late stage type 2 diabetes, the pancreas stops working completely, right? So now they don't have a response to insulin, but they also have to inject themselves with insulin like a type 1 diabetic. And that's not the initial stages of type 2 diabetes, but late stage type 2 diabetics will be insulin dependent as well, just like type 1 diabetics. So, yeah,
Do
Andy?
you see a physical like decrease in the size of the pancreas if there's
It's a good question. Yeah, I don't know about a physical decrease in the size, but the kind of gold standard way to measure beta cell health is beta cell mass, and that's done mostly in animals because you have to take the pancreas out and actually just find the beta cells and see how many of them are there. So I don't know if that's really enough to actually change the size of the pancreas, but definitely on a microscopic level, that is exactly how they measure it, is how many beta cells are left. But yeah, I don't know if that actually changes it physically. It's a good question. Other questions on that? Okay, so, oh yeah, here it was. I had the numbers here, but yeah, here's the hemoglobin A1C numbers for diagnostic criteria. But again, even before prediabetes, insulin resistance was there as well, right? And so diabetes itself is damaging, but really it's the kind of secondary consequences of type 2 diabetes that are problematic, right? So type 2 diabetics are 2 to 4 times more likely to have a heart attack or stroke. Okay, they most of the time head towards kidney failure because of all that excessive amounts of glucose they have to deal with. That damages kidneys, leads to blindness eventually. Problem is, glucose tends to stick to things, right? And glucose sticks to our blood vessels, it sticks to our neurons, it sticks to our kidney tubules, and it leads to what's called glucotoxicity, right? It was just kind of the toxic effects of too much glucose in our blood, and it damages all of those tissues. I don't have it on here, but Alzheimer's disease is known as type 3 diabetes. If you just Google type 3 diabetes, you'll see Alzheimer's disease. And so the connection between hyperglycemia and destruction of our brains is very tightly linked, right? And so not most, but a lot of type 2 diabetics will end up with some form of dementia and potentially Alzheimer's disease because high levels of glucose are so destructive to our neurons. Yeah, so the treatments, obviously diet modification, exercise is crucial for type 2 diabetics. Just one single bout of exercise increases insulin sensitivity and glucose control for 3 days at a time, right? So just a single bout of exercise activates all that extra GLUT4 going to the surface, and it improves our response to insulin as well, and it lasts for 3 days, right? And so sure, it's recommended to exercise 5 days a week and all these things, right? But if your grandma tells you I can't do that, but I know I need to for my diabetes. Tell her just exercise once. That's it. That's better than nothing, right? Because that's 3 days of better glucose control for that week, right? So the effects of exercise are dramatic. Weight loss is definitely connected to improvements in type 2 diabetes. Metformin is the most common treatment, which kind of helps with the mechanism that's broken of insulin resistance, and then long-term insulin injections if needed in the end. Questions on that? Yeah. Oh, yeah. So that is just describing what hemoglobin A1C is. So hemoglobin A1C is another way to measure glucose levels, right? But it's looking at the percentage of our hemoglobin that has glucose bound to it. And it's really looks at, like, instead of just getting a fasting glucose level, which we normally do, that gives us a general idea of what the average glucose was over a month to 2 month period. And so that's why that's kind of the gold standard way to to look at kind of glucose control in diabetics is the hemoglobin A1C, because it gives more of an average over a couple months versus just one time point with fasting. So thanks for reminding me to talk about that. Okay, other questions? Okay, and then just lastly, we typically think about type 2 diabetes as just about that insulin resistance factor, which is one of the factors, but there's 3 kind of key factors that are related to the pathophys of type 2 diabetes. One of those is this one here, decreased insulin signaling, which is the insulin resistance we've been talking about, which is tightly linked to mitochondrial function. And it's tightly linked to our skeletal muscle cells. About 75 to 80% of glucose disposal happens in our skeletal muscle cells. So it's a big part of type 2 diabetes is our skeletal muscle. And fat buildup in our cells can lead to that too. So that's one, that's the insulin resistance part. The other part that I've already mentioned is our beta cells start declining in type 2 diabetes as well. Like I said, when diagnosis occurs, there's typically only about 40% of the beta cells left, right? And so insulin secretion declines. And then the other big piece we haven't talked about yet is the liver. So HGP stands for hepatic glucose production. So the fat that's built up around our organs and in our abdominal cavity is called visceral fat. Visceral fat is highly metabolically active, meaning that it releases a lot of triglycerides into our blood all the time. And we have one depot of visceral fat that's close, right next to what's called our portal vein. And our portal vein is the one that takes blood from our digestive tract and dumps it into the liver. And if we have a lot of visceral fat in that area, we end up putting a lot of triglycerides into that portal vein, which goes right into our liver, which leads to fat buildup in our liver, right? So hepatic fat buildup is then directly connected to the liver not responding to insulin anymore. So we lose insulin sensitivity in the liver. And when we eat a meal, we get glucose into our blood. That glucose causes insulin to be released. Insulin goes to our liver and says, we got plenty of glucose on board, don't release any more glucose, right? But in type 2 diabetics, that mechanism doesn't work anymore, and the liver just keeps dumping glucose into the blood all the time. And so that's a big piece of what leads to the hyperglycemia in type 2 diabetics too. Okay. Questions on any of that? Yeah, go ahead.
Is for cell function sign.
For all 3, yeah, 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 good question. Other questions? Okay, I made a few kind of review questions for all the hormone stuff that we'll do via poll everywhere. So get whatever device out you want to get out to do that, and we'll get that going here. Okay, I think we'll try to make this big again, see if it works. Oh, it's staying today, good. Okay. I'll start that timer over. I don't know why it started already, but go ahead and get added there. I can move, you can also type it in too. So it should let you choose more than two. I looked up how, or more than one. I looked up how to do that. Hopefully that's working. But yeah, chat with the people around you on each of these questions. We'll do one at a time, but talk with your classmates about it as well and decide which ones you think are correct and send it in. We need more time, probably, huh? Sorry. I think I can just unlock it again. There we go. You can keep answering. All right. Think everybody got a chance to answer there. Let's take a look at the correctness here. Okay. So let's talk about each of these. Okay. So the adrenal medulla is glandular tissue that releases hormones into the blood. What's wrong with that one? What's the adrenal medulla made of? Neurons. Adrenal medulla is neurons, right? And it releases neurohormones into the blood. This is on the recording too, just so you know. I'm recording this so you can see these questions from the video if you want. You can also take pictures, I don't care. But yeah, adrenal cortex is glandular tissues that releases neurohormones in the blood. What's wrong with that one? Should be what? Or could, that would work, yeah. Adrenal medulla would work. It would also work if it said just hormones into the blood, right? Not neurohormones. Glands release hormones into the blood, right? Neurons releasing neurohormones into the blood, or neurons can release neurotransmitters into a synapse, right? Those would be the kind of the three that work. Okay, so the hypothalamus does contain neurons, right? That release neurohormones into the blood, so that's a neurohormone system, right? The thyroid gland doesn't release neurotransmitters, right? It releases hormones because it's a gland releasing into the blood. Anterior pituitary does it's glandular tissue that releases hormones into the blood, not neurohormones. Okay. Posterior pituitary is neurons, right? It's just axons of the hypothalamus that come down, and those are releasing neurohormones into the blood. Okay. Hormones released from the adrenal cortex are all what kind of hormones? Not amine hormones, but steroid hormones, right? They're all cholesterol-based hormones. Okay. Hormones released from the adrenal medulla are all amine hormones. That one is true. So the catecholamines, right? Epinephrine, norepinephrine, dopamine are all amine hormones. Yeah, go ahead. Hormones, yeah. Yep, exactly. Okay. Other questions? Yeah. Okay. Let's go to the second question. Chat with each other. Make sure you're on the same page. Oh, here. Guess we'll just go here. That way it's better. Then you guys can't be influenced by each other. Unless you can see it on your phones. I don't know. Bless you. Oh, good. Now I can see the number. There we go. It's better. All right. Anybody else? I think there's about 36 of you or so, but we're close. Okay. All right. Let's see what you guys said here. Okay. So most of you are saying to drop off hypothalamic hormones. And the correct answer would be to pick up hypothalamic hormones. Okay. So if we think about hypothalamus is here, got this little stalk kind of connecting down to the pituitary gland. Okay. We're talking about the anterior side here. We have a capillary bed right there in that stalk part, right? So the hypothalamus has neurons that go just that far to that part, right? So it releases neurohormones right there into the stalk part. We've got to pick those up to get them down to the pituitary gland, right? So maybe it's just the verbiage of pick up versus drop off, but as long as you understand it, that's the key part. The capillary bed there is to pick up those hypothalamic hormones, carry them down via the bloodstream to the anterior pituitary. And then that second capillary bed would have two roles, right? It would be to drop off those hypothalamic hormones there so they can interact with the pituitary. And then secondly, the pituitary is going to release hormones. That same capillary bed picks those up so they can go out to the bloodstream, right? Yeah, Andy?
Because this is in the infundibulum, that's why it's just picking up.
Yep, exactly. It's the first capillary bed up top before we get down to the other one. Yeah. Yeah.
How do you date the first part of that, of the hypothalamus dropping, like, the beginning, like dropping off, so that they could be picked up?
Because we're talking about like the blood doing this, right? So like the capillary bed is what we're talking about, right? So the hypothalamus does have to drop off hormones, right? In that first part, but that's the neurons dropping them off, right? And then we need to pick them up. So it's asking what's the role of the capillary bed, right? Which is the blood. So maybe that's the confusion. Yeah, great question. Thank you. Yeah. Yeah. So this is the role of the vascular system here, not the role of what the neurons are doing. Yeah. But that's a great clarification. Okay, let's go to the next one. All right. What do we got? All right, maybe we won't get done early, but sorry. Did never say that. It's only letting you choose one? No, shit. It's really only letting you choose one? Yeah. All right, well, I tried to make it let you choose more than one, but I guess I messed that one up. So just pick one and then we can talk about them. All right. Anybody else? Good. Okay, let's take a look at what you guys said. Yeah, we'll just walk through each of these. The reason I brought this question up is because most of the time we think of issues with cortisol when we think of this, right? But really a lot of the symptoms have to do with aldosterone. And so definitely salt cravings and low sodium. When we have too much aldosterone causes us to get rid of potassium, right? And so Addisonian crisis is when we don't have enough aldosterone, right? And so when we don't have enough aldosterone, we let go of too much sodium, right? And then we can't get rid of potassium because that's what aldosterone does, right? So those ones are connected. Orthostatic hypotension has to do with low blood pressure, right? Because of the electrolyte imbalance that we have. And then obviously low blood pressure is connected to that. So those would be the correct ones there. Questions on that one? Okay, couple more here. See if you can choose more than one on this. Nope. Still not, Alexis? Oh, you can? Okay, good. Yeah, talk please about it here. Decide what you guys think. What could result in a goiter and hyperthyroidism? All right, let's see what you guys said here. So we've got, yeah, so Graves' disease, we didn't talk about Graves' disease leading to a goiter, but the pathology with Graves' disease is antibodies that activate TSH receptors, right? And those TSH receptors cause growth, right? And so you can get a goiter from Graves' disease. Low iodine intake can lead to a goiter, but that would lead to hypothyroidism, not hyperthyroidism, right? Excessive iodine intake, no. Low TSH, no, but then an anterior pituitary tumor can lead to excessive amounts of TSH release, which can lead to too much thyroid hormone, which would be hyperthyroidism and too much growth of the thyroid gland for the goiter. Okay, go ahead, yeah. Just because it's the thyroid gland is going to make what it needs to make, right? It's not going to be like forced to make anything that is. But even with that, because you were thinking that would cause too much thyroid hormone release, but then still it's all about TSH, not about thyroid hormone release. But yeah, yeah, good. Okay, all right, couple more here. Can you see the whole thing? Yeah, on yours you can. All right, check with your partner there. See what they put. All right, let's see what you guys said. All right, good. So 2/3 of you got the right answer, which would be parathyroid hormone leads to calcium resorption from bone and raising of blood calcium, whereas calcitrol leads to increased GI absorption of calcium and decreased excretion, or we could say inhibited, or we could say increased reabsorption, right? Would be another way to say that. But yeah, good. Okay. All right. Two more. All right, how we doing? Still going up, it looks like. Let's take a look here. All right, so what do we got? So FSH stimulates follicular growth. Okay, that's our first one. The next one, estrogen stimulates endometrial growth. LH stimulates ovulation. Okay, progesterone stimulates mucus release from the endometrium. That's primary effects there. And then lastly, the decrease in progesterone directly leads to menstruation because we lose the maintenance of that endometrial layer. Okay, last one is a different type of question. I have no idea how it'll come out, but let's take a look. So you guys get to pick on here where exogenous testosterone use would mess with this hormone loop. Okay, so you can click on there. I can't remember if I let you click multiple places. Give it a shot. All right, anybody else? Can you click more than one place or is it just one? This one. Okay. I'll go ahead and yeah, let's take a look at your responses here. Okay. All over the place. Regions, what does this show us? I don't know what that shows us. Show everything. Okay. Well, that's probably easiest to talk about it just going back here. We could say that it messes with the negative feedback over here. That would be one of the things I was thinking for sure, right? If we give too much negative feedback, now we're not releasing FSH and LH, right? So we could also say that messes with FSH release, which would mess with the ability of these Sertoli cells to help the sperm development. We could say it messes with the release of LH. That wouldn't matter too much because that is mostly just causing testosterone, which you're getting a lot of that anyways. Yeah, so the main ones I was thinking would be the negative feedback and kind of this part here with FSH and LH, but you could convince me of other ones too, I'm sure. But questions on any of that? Yeah, go ahead. Okay. Yeah, definitely connected too, right? But it's kind of just one step back, right? Estrogen's causing the release of LH, right? And then LH is causing the ovulation. So it's just a step back, but yeah. But it's that surge of estrogen or it's the lots of estrogen that causes the surge of LH. So yeah, good question. All right, guys, all done. Good luck on your test on Friday. We'll see you guys next week.